Welcome. My name is Dr. Peter Schnatz, and it is a pleasure to welcome you today to our International Menopause Society Symposium on Osteoporosis, titled Osteoporosis for Midlife Women and Beyond. You're in for a wonderful treat today, and I believe quite a powerful presentation with two wonderful colleagues, individuals that I've had the pleasure of getting to know over a number of years. And before I introduce both of our presenters, I just want to remind everybody that this webinar today has been supported by an unrestricted educational grant from Basing Healthcare. Basing's Healthcare has no role in the selection of topics, selection of speakers, and have not vetted, reviewed the content of the speakers' presentations. Again, our topic and title is Osteoporosis for Midlife Women and Beyond, and our two presenters today will be Dr. Michael Lewicki and Dr. Michael McClung. Dr. Michael Lewicki will present first. His topic will be a review of the current guidelines on the diagnosis and when to treat in the osteoporosis patient. Dr. Lewicki is the director of the New Mexico Clinical Research and Osteoporosis Center and Director of Bone Health Tel-Echo at the University of New Mexico Health Sciences Center in Albuquerque, New Mexico. He's a consultant in osteoporosis and metabolic bone disease, supervisor and interpreter of bone density studies, and an educator with special interest in the evaluation and treatment of osteoporosis and metabolic bone diseases. He's been the principal investigator for many osteoporosis clinical trials and is an author of over 300 publications in peer-reviewed medical journals, as well as books, book chapters, and online publications in osteoporosis. Dr. Lewicki is the program director of the annual Santa Fe Bone Symposium, the flagship activity of the OFNM. He's a past president of the International Society for Clinical Densitometry and founding president of the Osteoporosis Foundation of New Mexico. He's an editor for Osteoporosis International and is on the editorial boards of the Journal of Bone and Mineral Research and the Journal of Clinical Densitometry, and has received national and international awards that include the 2021 John Belzikian Global Leadership Award and the 2021 Lawrence Reutz Memorial Lecture Award with the Bone Health and Osteoporosis Foundation. Our second presentation by Dr. Michael McClung will be the current and best therapeutic options. Dr. McClung is an endocrinologist with special interest in metabolic bone diseases and disorders of calcium metabolism. And as the founding and now emeritus director of the Oregon Osteoporosis Center in Portland, Dr. McClung has for the past 4 decades cared for patients with osteoporosis and related conditions. He developed quality control procedures for bone density testing, has been involved in many major clinical trials of osteoporosis treatment, and has participated in the development of osteoporosis guidelines for several national and international organizations, including the International Menopause Society, as well as the North American Menopause Society. He's an author of many peer-reviewed manuscripts and invited papers, and currently serves on the boards of the International Osteoporosis Foundation and NAMS, and on editorial boards of a number of journals related to metabolic bone diseases. He's currently a professorial fellow at the Mary MacKillop Centre of Health Research at the Australian Catholic University in Melbourne, and has received teaching awards from several societies and is frequently invited as a speaker teacher at national and international clinical conferences. Without further ado, I'd like to turn it over to Professor Lewicki for our first presentation on reviewing of the current guidelines on diagnosis and when to treat.
Well, thank you, Peter, for the kind introduction. I'm going to talk about guidelines on the diagnosis and indications for treatment. Here is my disclosure. Perhaps the most relevant is that I've been involved in guideline development for a number of organizations that you see here. So if perhaps you don't like some of the things in the guidelines, I'm probably at least partially to blame. Here are my objectives. I'm going to discuss current standards for diagnosing osteoporosis, review medications and conditions with harmful skeletal effects, and present recommendations for initiating pharmacological therapy for prevention and for treatment of osteoporosis. And then Mike McClung will go on to talk about specific therapeutic agents. When we're talking about the guidelines and recommendations and data from clinical trials, we don't want to lose sight that medicine is all about people, and osteoporosis is about people breaking bones. And it can affect all of us personally. This is a photo from my family album. This is Aunt Edna. This is the same woman in both of these photographs. On the left, you see her in her 50s. She's a fine, straight standing woman who's vigorous and active. And on the right, you see Aunt Edna in her 70s when she suffered from severe postmenopausal osteoporosis with multiple vertebral fractures. In those days, when Aunt Edna was around, we didn't have any good treatments for osteoporosis other than estrogen, and she did not take estrogen because she was not having hot flashes. And she died shortly after that second photo was taken. So I think the goal for all of us is that none of us in the future have people like Aunt Edna in their photo albums, that our patients don't wind up like Aunt Edna, and that we ourselves don't end up having fractures that might have been prevented. And what Aunt Edna had is a preventable disease, and this could have been treated with medications that we currently have. We do have a lot of guidelines. I'd venture to say too many of them. On the left, you see just a few of the more current guidelines. The Bone Health and Osteoporosis Foundation, formerly the National Osteoporosis Foundation of the US, just released guidelines this year. That's available as an EPUB. American Association of Clinical Endocrinologists, Endocrine Society, and NAMS. And I'm going to focus today on NAMS guidelines because they're very recent, and it comes from an organization that has a very strong interest in a broad range of menopausal issues. The ISCD has guidelines that are mostly focused on diagnosis and quality standards for bone density testing. And in an effort towards harmonization of guidelines, the National Osteoporosis Foundation in the US, Osteoporosis Canada, and the National Academy in Mexico not too long ago published a paper taking a small first step toward harmonizing guidelines, and hopefully these organizations will get together in the future and take some additional steps towards greater standardization of guidelines. On the right panel, you see some of the differences of guidelines. Sometimes they address different patient populations, sometimes women only, sometimes men only, sometimes both, glucocorticoid-induced osteoporosis sometimes. They may have different treatment goals. Some are focused on preventing fractures, others are focused on preventing osteoporosis from developing in the first place. They're directed to different audiences with different specialties sometimes. Some are applicable to specific countries and regions. There's different methods of development, some of which depend more or less on expert opinion. And they go by different names, which may imply subtle differences in the goals. Some are called guides, some guidelines, some position statements, official positions, or consensus. So we'll go on to talk about the NAMS guidelines. It's my feeling that all guidelines are actually wrong in the sense that you can find many exceptions to the guidelines in taking care of individual patients that don't seem to fit well with how the guidelines are going. But good ones are useful, I think, because they provide a framework for making clinical decisions. And somewhere in almost all guidelines, usually buried towards the end of the publication, there's a statement that says something like treatment decisions should be individualized. And I think that's the bottom line and maybe the most important thing about all guidelines. We need to consider the guidelines if they're appropriate, but we have to take care of an individual patient sitting across from us in a room who may have very specific issues. So here is a postmenopausal woman. Let's imagine she's had a recent fracture. And these are some of the things that come up in the course of the conversation. She might tell me, anyone would have broken a bone if they fell this hard. No one in my family has osteoporosis. I only want natural treatment. Why do I need a drug? What are the side effects? Don't these drugs cause brittle bones and rotten jaw? How long do I have to take it? What is the cause? And many more questions. And this can take a long conversation sometimes. And sometimes we don't have enough time to cover all of this. And these are the sorts of questions we can cover in the Q&A if there's interested in doing that. So what do we do with this patient? Well, first, we want to evaluate fracture risk with the tools that we have available, such as bone density testing and fracture risk algorithms and past medical history. We want to determine whether fracture risk is high enough that pharmacological therapy is indicated. Then we need to evaluate the patient for factors contributing to skeletal fragility and have a discussion about these results with the patient. Then we have to select an individual therapeutic agent that we think is the best for starting therapy. And finally, we have to follow up to be sure that the patient takes the treatment correctly and long enough in order to benefit from the goals of our treatment. So I'm going to focus on the first part of this. Mike McClung will focus on treatment. So I'll talk about fracture risk assessment, intervention thresholds, and evaluation and discussion. These are the indications from the NAMS guidelines for bone density testing. And this is applicable to postmenopausal women. So age 65 and older should have a bone density test. Women age 50 to 65 with at least one of the following risk factors should have a bone density test. If there's been a fracture since menopause, if there's a known medical cause of bone loss or fracture, plus vertebral imaging should be done in women age 70 and older who have had historical height loss of greater than 1.5 inches. And what you see on the image to the right is a wall-mounted stadiometer. So if you're interested in accurately determining whether a woman has had loss of height, this is the way to do it, rather than a floppy arm that comes out from a standard office scale. And some of these stadiometers can measure height with an accuracy of 1/2 of 1 millimeter. And historical loss of height is a trigger for doing vertebral imaging because these patients are at higher than average risk for having unrecognized vertebral fractures, and identification of a previously unrecognized vertebral fracture may change diagnostic classification, might change your assessment of fracture risk, and it might change your decision to treat or how to treat. These are the World Health Organization diagnostic criteria according to DEXA. Normal is a T-score minus 1.0 or greater. Osteopenia, also called low bone mass, is T-score between -1 and -2.5. Osteoporosis is less than or equal to -2.5. And severe osteoporosis, also called established osteoporosis, means a T-score in the osteoporosis range and the presence of a fragility fracture. T-scores, however, don't tell us the whole story. A T-score that's minus 2.5 and below is not always osteoporosis. For example, it could be osteomalacia, a disorder of bone mineralization. It could be osteogenesis imperfecta, which means abnormal bone collagen. T-score greater than minus 2.5 may be osteoporosis. For example, when a fracture has occurred, most guidelines will say that you can make a diagnosis of osteoporosis independently of bone density. And at least in the US, we can make a diagnosis of osteoporosis in some cases when there's a high fracture probability by FRAX, even though T-score is greater than minus 2.5. Keep in mind that T-scores apply to postmenopausal women and perimenopausal women, as well as men aged 50 and older. And in younger women, men and children, we use Z-scores, not T-scores, and the WHO diagnostic criteria do not apply in this case. The T-score may change when bone mineral density does not. So when we're doing quantitative comparisons with DEXA, we always want to compare BMD in gram per centimeter squares and not T-scores. And the reason is that the software in the DEXA systems may use different reference databases, which may change from time to time, altering the T-score when in some cases the bone mineral density may actually not be significantly different. And there are many risk factors for fracture in addition to T-score, especially age and prior fracture. So these are the three ways that we diagnose osteoporosis: when the T-score is minus 2.5 or below at the lumbar spine, total hip or femoral neck; when there's been a fragility of fracture, NAMS says vertebral fracture or hip fracture, regardless of BMD and risk factors. And NAMS also says that we can diagnose osteoporosis when the T-score is between minus 1 and minus 2.5, and there's been a fracture of the humerus, pelvis, or forearm, or multiple fractures at other sites, excluding the face, feet, and hands, or high fracture probability by FRAX. And in the US, that's defined as major osteoporotic fracture risk over 10 years, 20% or greater, or hip fracture risk 3% or greater. Having a fracture is not only a sentinel event in a patient's life, it indicates an urgency to evaluate and treat. And this has a label now. It's called imminent fracture risk. And that is a recognition that fracture risk is very high in the first 1 to 2 years after having a fracture. And it remains high afterwards, but not as high as it is initially. So here you see one of a number of studies illustrating this. Here we see that the risk of major osteoporotic fracture in the 5 years after hip, shoulder, or clinical vertebral fracture is very high in the first 1 to 2 years or so. So evaluation and treatment is urgent soon after a fracture. And fracture liaison services, or FLS, is a strategy to systematically identify fracture patients, usually in the hospital setting, enter them into a registry and track their progress after hospital discharge to assume that they're evaluated and treated appropriately. We have fracture risk algorithms that can estimate fracture risk. FRAX is the one that's most widely used worldwide. It has many benefits. It gives us a quantitative estimation of fracture risk. There are robust supporting data. It's part of DEXA software. There's a smartphone app for this, and FRAX is included in many clinical practice guidelines. However, not all risk factors are included in FRACs. There's a dichotomous input, that is, we answer yes or no to risk factors, even though there may be a range of risk associated with the duration or severity of exposure. It has a range of error that's not very well defined. The only bone density input, if we have one, is femoral neck BMD. And in the US, we're limited to 4 ethnicities. And if somebody is a mix of ethnicities or unknown ethnicity, we have to guess about the right way to do this. So FRACS is helpful, but it's not the final word on what we ought to do in managing the patient. Before starting treatment, it's important to consider risk factors, that is, medications and conditions that have adverse skeletal effects. Certainly, for this audience, I think aromatase inhibitors is an important risk factor for bone loss and fracture. But there's many other medications. Long-term glucocorticoids is especially important because of its adverse skeletal effects. There are genetic disorders, endocrine diseases, hyperthyroidism, for example, whether it be endogenous or from excess thyroid replacement. Eating disorders, vitamin D deficiency, other nutritional deficiencies, and on and on. So I don't have time to go through the whole list, but we need to recognize that these factors can be important, and those that are modifiable ought to be addressed and modified if it's clinically appropriate. Baseline laboratory tests are important. NAMS recognizes that there are some routine tests that should probably be done in everyone. That begins with a complete blood count, which may be abnormal in situations such as myeloma or celiac disease. Serum calcium, albumin, and phosphate should be measured. In the US, we have a comprehensive metabolic panel that includes all of those, except usually not a phosphate. So if a phosphate is not included in a blood chemistry panel, we need to think about that and order that separately. And an abnormal phosphate may be present in the case of renal failure where it's too high, and it may be low in cases of hyperparathyroidism or renal phosphate wasting. And it's important to identify that early on before we start treatment. Many people would routinely do a serum 25 hydroxy vitamin D level as well. Do not order the 125 dihydroxy vitamin D, as that is not as good an indicator of body stores of vitamin D. And in some cases, serum PTH. I often order a 24-hour urinary calcium as a screening test for hypocalciuria, which may be an indicator of calcium malabsorption, or hypercalciuria, which can go along with other disorders that are important for bone health. And especially in older patients, consider myeloma and order some such screening test as a serum protein electrophoresis. In some cases, tryptase is screening test for mast cell disease, or TSH, especially if you suspect a thyroid disorder. These are indications for pharmacological therapy. In NAMS suggests we consider these for prevention of bone loss or for treatment of osteoporosis. So in the prevention side, which often gets forgotten in some of the other guidelines, consider treatment when there's premature menopause, at least until the natural age of menopause. When the T-score is less than minus 1.0 and there's rapid bone loss due to menopause transition or discontinuing estrogen, and when T-score is less than minus 1 and other risk factors are present. And for treatment of osteoporosis, if there's been a vertebral or hip fracture, if the T-score is minus 2.5 or below, or if the T-score is between minus 1 and mine is 2.5, and one of the sub-bullet risk factors are present to consider pharmacological therapy to reduce fracture risk. For those of you that may have a special interest in osteoporosis and want to learn more, or if you want to share your knowledge about osteoporosis with others, or if you have cases about osteoporosis and metabolic bone diseases that you'd like to present and get other opinions, there is something called Bone Health Echo. This has been called a virtual community of practice. The original Bone Health Echo was started at University of New Mexico in Albuquerque in 2015, and sessions have been held once a week since 2015, where we have brief slide presentations followed by interactive discussion, and case presentations followed by a discussion where everybody has a chance to ask their questions and make comments. And this gives you an indication of the reach within the United States. And beyond that, we've had people from every continent participate at one time or another. Since the original prototype Project Echo at University of New Mexico, there's been 8 other bone echo programs started up, most of them in the US, but 5 programs outside of the US, including Ireland, 2 in Russia, Sydney, Australia, combined with New Zealand, and 1 based in Beirut, Lebanon. All of them are different days of the week, different times, sometimes different languages. It's a great opportunity to get more involved with osteoporosis if you wish. So to summarize, BMD testing is indicated for all women age 65 and older, and younger postmenopausal women with risk factors. Osteoporosis may be diagnosed according to T-score, prior fracture, or at least in some cases by high fracture probability. Postmenopausal women at risk for bone loss and those with high fracture risk should be considered for pharmacological therapy. Before starting pharmacological therapy, evaluating for contributing factors should be performed. And for anyone who wants more information about Bone Health Echo, feel free to contact me at the email address you see here. And if you can't remember that, just Google bone and echo, and you'll get lots of links for more information. So I'd like to thank you for your attention. I look forward to Mike McClung's talk and Q&A to follow.
Professor Lewicki, thanks so much for the presentation. We're going to hold questions for now. Feel free to put your questions in the Q&A box, and we will move on to Professor McClung.
All right, thank you, Peter, and good day to everyone. I'm also very pleased to be a part of this program. My friend and colleague, Dr. Lewicki, has set up the stage to talk about current therapeutic options. And please, on this slide, note my disclosures and financial relationships, most pertinently with Amgen. So as already has been mentioned, osteoporosis is a chronic, incurable condition that consists of 2 components, not only low bone mass, but also because and as a result of the bone loss that occurs, there is a deterioration in trabecular structure, weakening the skeleton and increasing fracture risk. While general measures such as adequate nutrition, regular physical activity, and avoiding harmful lifestyle habits are important, those general measures are not sufficient to either prevent or certainly not to treat osteoporosis once present. For patients deemed to be at high fracture risk, then the strategy for reducing fracture risk involves the use of pharmacologic therapy. Over the past 25 years, a whole menu of treatment options has been developed. These drugs have different mechanisms of action, different contraindications, different side effects, and different potencies. And so selecting among the various treatment options is one of the arts of managing patients with osteoporosis. Some important pearls about osteoporosis treatment. like virtually every drug, the benefits of treatment disappear sometimes very quickly when therapy is stopped. So there is no short-term solution to treating osteoporosis because whatever benefits happen while on therapy quickly disappear when treatment is discontinued. The optimal management of a postmenopausal woman with osteoporosis over her lifetime will likely include the use of multiple drugs in various sequences over that time. And with that in mind, it's important to understand where different drugs might fit in sequences and to develop a strategy for long-term treatment, even at the outset of therapy. The sequence with which drugs are given, as we'll talk about, may have very important clinical ramifications. So the drugs available for osteoporosis come in two major categories. There are anti-remodeling, often called anti-resorptive drugs that include the drugs we're most familiar with, including estrogen agonists, bisphosphonates, and denosumab, the rank ligand inhibitor. These drugs not only inhibit bone resorption, their major mechanism of action, but they also inhibit bone formation. And as a consequence, these drugs cannot and do not restore the architectural deficit that characterizes osteoporosis. The other category includes bone forming or osteoanabolic drugs. This includes parathyroid hormone receptor activators, teriparatide, and in our country, abaloparatide, that increase both bone formation and bone resorption. And then in addition, there is an anti-sclerostin drug, romosozumab, that has a dual mechanism of stimulating bone formation while simultaneously decreasing bone resorption. So let me then think about these drugs individually and where they might have their most important role in managing patients with osteoporosis. The choice of the initial therapy is thought to be importantly determined and decided by the level of risk of the patient. For patients who are at low risk, that is women who don't yet have osteoporosis, then hormone therapy or low-dose bisphosphonate as an alternative are approved for preventing osteoporosis. For women who do have postmenopausal osteoporosis, but who are at moderate risk and who are not at high risk for hip fracture, raloxifene has a role, as we'll talk about. For patients thought to be at high risk for osteoporosis, that would include women who have osteoporosis by bone density criteria and or a remote history of fractures, then anti-remodeling agents, bisphosphonates and denosumab are typically recommended. And then for patients at very high risk, that would include women characterized by a recent fracture, very low bone density, or very high fracture probability by a tool such as FRAX. It's in those patients that the bone building drugs are typically recommended. So let me present 4 cases to exemplify the choice of drugs. The first is a healthy 52-year-old woman who is recently menopausal with hot flashes. She's thin, which is an important risk factor for having low bone density, and she has a family history of osteoporosis. She has not personally had a fracture and does not have other risk factors for osteoporosis. She is a candidate for DEXA testing by virtue of her thinness and her family history, and those results show low bone density. They are not in the osteoporosis range. She is currently at low fracture risk. However, because she is poised to on the brink of a phase of relatively rapid bone loss, she is a candidate for therapy to prevent that rapid bone loss with estrogen, or as a second choice, one of the bisphosphonates. There is, as all of you who manage menopausal women know, a phase of relatively rapid bone loss that occurs for an interval of 5 to 7 years over the menopausal transition. In the SWAN study and other studies, it's shown that the average loss of bone density over that menopausal transition is somewhere in the range of 10 to 12%. That's a T-score unit of bone density. During that phase of rapid bone loss, the architectural destruction is particularly devastating. The damage to the trabecular architecture is greater in individuals with rapid bone loss compared to those who experience the same amount of bone loss, but over a much longer time period. And the iliac crest biopsy images shown here show a deterioration in bone architecture in a patient who was in a placebo group. This was a young menopausal woman enrolled in a clinical trial with obvious deterioration in her trabecular architecture over only a year's time, and the ability of anti-remodeling drugs like bisphosphonates or estrogen to prevent that deterioration. So as another evidence of architectural deterioration, in the 5 years before through 5 years after the final menstrual period, the measurement of spinal trabecular bone score, an indirect measure of trabecular architecture, declines by about 6.3%. Once that deterioration in structure has happened, drugs like estrogen and bisphosphonates do not restore that disordered architecture. Estrogen, relaxin, and bisphosphonates have government approval for osteoporosis prevention. And candidates for therapy have already been outlined by Dr. Lewicki, including women with low bone density who are about to experience rapid bone loss in early menopause or who discontinue estrogen. So we know that estrogen with or without progestin or basidoxifene are effective in preventing the bone loss for as long as the estrogen is taken. In the Women's Health Initiative, which was not specifically designed to be an osteoporosis study, women who were enrolled were on average in their early 60s. They were not selected to have osteoporosis. And in those low-risk patients, there was clear evidence of fracture protection over the 5 or 6 years of estrogen therapy. Fracture risk was also reduced with estrogen in the older Danish osteoporosis study published many years ago. However, as stated earlier, the skeletal benefits of estrogen on both bone density and fracture protection are quickly lost when estrogen is discontinued. We know that we can prevent that loss with bisphosphonate therapy. And so shown in this slide, in the left-hand panel, are results of spinal bone density changes in women who received estrogen progestin for 4 years, with an increase in bone density of about 6%, while the placebo group was experiencing bone loss in these early postmenopausal women. Then after 4 years, estrogen was discontinued, and all of the gain that had been realized was lost within the next 12 months. And ultimately, within 2 or 3 years, the bone density in the women who had been on estrogen resembled the bone density in women who never took estrogen. Shown in the right-hand panel are older data showing that if women discontinued estrogen and were randomly assigned to receive either alendronate or placebo, that the bone density was maintained. And in a study that Dr. Watson and I presented at NAMS a few years ago, as women discontinued estrogen, they were randomly assigned to receive either alendronate or raloxifene. As was shown in the previous slide, alendronate prevented bone loss from happening in both the spine and the hip. Raloxifene was partially, but not totally effective, not surprising since raloxifene is a weaker estrogen agonist than, of course, is estrogen itself. Each of the 4 bisphosphonates that are available for osteoporosis treatment are also approved for osteoporosis prevention, but the doses of alendronate and zoledronate approved for prevention are smaller than the doses that are used for osteoporosis treatment. So for women who are candidates for prevention therapy, but who cannot or will not take estrogen, bisphosphonates are an alternative. It would be important to continue bisphosphonate therapy during the interval of relatively rapid bone loss. And if prevention of bone loss is successful, then after that phase of rapid bone loss has been completed, the bisphosphonate could be discontinued the patient monitored, and then treatment restarted if or when evidence of bone loss was observed. There are other estrogen agonists that include tibolone, available in many countries. This drug appears to be equipotent with estrogen and could be used interchangeably with hormone therapy for its skeletal benefits. Raloxifene, again, a weaker estrogen agonist, as I mentioned, is not capable of fully preventing the bone loss in early menopause, and it may increase the frequency and severity of vasomotor symptoms, so is typically not the ideal choice for preventing bone loss in early menopause. In studies in women with osteoporosis, raloxifene reduces vertebral fracture, but has minimal or no effect on non-vertebral, including hip fracture, and has an estrogen-like risk of venous thrombosis. So its role in the management of patients with osteoporosis would be to treat younger postmenopausal women who are beyond the rapid phase of bone loss and who no longer experience vasomotor symptoms, and who are not yet at high risk for hip fracture, particularly in women who have concerns about breast cancer risk because of that added benefit of raloxifene. So an example of where raloxifene might be used is this case: a healthy 58-year-old woman who's 10 years beyond menopause and no longer has vasomotor symptoms. Because of a family history of osteoporosis, a DEXA test was performed. She has bone density values that meet the criteria for osteoporosis. She's not had a history of fracture, has no other risk factors for fracture, nor risk factors for venous thrombosis. So she meets the criteria for therapy, and in my view, would be a candidate for raloxifene, which could be continued until her risk for hip fracture increases by virtue of increasing age, to the point that a therapy that specifically prevents hip fracture would be warranted. The third case would be a 65-year-old woman who had her first DEXA test revealing osteoporosis with values in both the spine and the hip meeting that criteria. She had a risk fracture 8 years ago, but no other risk factors. She has normal renal function and no gastrointestinal symptoms to preclude the use of bisphosphonates. She meets the criteria, as Dr. Lewicki outlined, for being at high risk of fracture, and then is a candidate for either a bisphosphonate or denosumab. The bisphosphonates come in both oral and IV preparations. They have been very effective in reducing the risks of vertebral, non-verbal, and hip fracture. There are very important dosing rules, as you know, for oral bisphosphonate therapy. GI distress, muscle pain, and rare instance of osteonecrosis of the jaw are important adverse events. Importantly, there is no additional benefit of bisphosphonate therapy beyond 5 years. I'll show you that in a moment. But therapy beyond 5 years is associated with an increasing risk of atypical fracture, with the risk being approximately 1 in 1,000 patients after 8 to 10 years of bisphosphonate therapy. Shown in the upper panel are hip bone density changes over 9 years therapy with zoledronate, showing the typical increase that we see during the first few years, and then a plateau after 4 to 5 years. This is seen in all of the long-term osteoporosis studies. Shown in the lower panel is the age-adjusted risk of atypical fracture as a function of duration of therapy, with very low risk during the first few years of therapy, and then beyond 5 years, the risk increases quite substantially. Those situations led to the consideration of the so-called drug holiday, that we can take advantage of the relatively slow offset fracture protection upon stopping a bisphosphonate and we can consider temporary interruption of therapy after 3 to 5 years in patients who at that point are at low fracture risk. So after 3 to 5 years of bisphosphonate therapy, treatment could be temporarily stopped if the patient no longer meets the criteria for therapy. Then the patient should be monitored with bone density and clinical history every year or two, and therapy should be restarted when the patient again meets the criteria for being on therapy. For patients who remain at high fracture risk after 3 to 5 years of bisphosphonate therapy, continuing treatment is important. But based on what I said on the previous slide, I feel there's no justification for continuing bisphosphonates for more than 5 years at a time in any individual patients. So for those patients who remain at high risk after 3 to 5 years of therapy, I would consider switching to another drug like denosumab or a bone building drug. Shown here are the results of hip bone density changes over 10 years of denosumab therapy, shown in the top panel, with a progressive increase over that full 10 years time. And shown in the lower panel are the results of 4 separate studies in which patients who have been on bisphosphonates were transitioned to denosumab, and in each case there was an additional improvement in hip bone density in those who switched from a bisphosphonate to denosumab. So denosumab is a fully human monoclonal anti-rank ligand antibody that is administered subcutaneously every 6 months. In a very large placebo-controlled trial, fracture risk reduction was documented with the risk reductions noted there. As I've mentioned, there is a progressive improvement in bone density over at least 10 years, and evidence that there is additional non-vertebral fracture protection with longer-term treatment. There is no limit to the duration of therapy. The clinical trial experience extends out to 10 years, and there was no duration-dependent increased risk of any adverse event over that 10 years time. Like estrogen, there is a very rapid offset of the skeletal benefits, including a protection from vertebral fracture when treatment is discontinued. So if, for whatever reason, treatment is stopped, then follow-on therapy with intravenous IV zoledronate and careful monitoring to consider a second dose of zoledronate is important to minimize the rebound in bone remodeling and the rapid bone loss that occurs when denosumab is discontinued. The safety concerns with denosumab included skin rash and cellulitis that happen more frequently with therapy compared to placebo, but in the long-term follow-up of patients over 10 years, those risks did not increase and no other new risks were developed. Rare cases of osteonecrosis of the jaw and atypical fracture have been reported with denosumab. The third case that we mentioned, the lady who was a candidate for a bisphosphonate or denosumab, if bisphosphonates are chosen, then her risk should be reevaluated after 3 to 5 years to determine the next step in her management. If denosumab is chosen, then therapy can be continued long-term, but if discontinued, we need to take steps to prevent the rapid loss of bone density in that situation. And the last case is a patient who meets the criteria for being at very high risk of fracture. She's a 71-year-old woman who had a humerus fracture several years ago and recently experienced 2 vertebral fractures while gardening. The recency of a fracture is by far the strongest risk factor for having another fracture, and patients with recent fractures meet the criteria for being at very high risk. Her workup for secondary causes was negative. Her lumbar spine bone density value is quite low, and as a consequence of that history and bone density value, she is deemed to be at very high risk of fracture and is a candidate for a bone building drug to be followed by an anti-remodeling drug. The PTH receptor analogs, teriparatide and abaloparatide, are given by daily subcutaneous injection for 18 to 24 months. The limit for therapy is driven mainly because the bone building effects of all of the bone building drugs gradually diminishes over time. And so that's why the duration of therapy is limited to a year or 2. In clinical trials, both of these drugs result in substantial reduction in vertebral fracture risk and evidence of non-vertebral fracture risk reduction, but no direct evidence for hip fracture risk reduction. The adverse events include hypercalcemia, an extension of how these drugs work, and orthostatic hypotension at the beginning of therapy. These drugs are not to be used in patients who are at risk for osteosarcoma. Romosozumab is the other bone-building drug, an anti-sclerostin antibody. Sclerostin is an endogenous inhibitor of bone formation, and by inhibiting the action of that protein, then bone formation is activated while resorption is inhibited. Romosozumab is given by monthly subcutaneous injections over an interval of 12 months. Fracture risk reduction in studies was demonstrated. After 12 months, there was a 73% reduction in vertebral fracture risk compared to placebo, and a 37% reduction compared to alendronate. And in patients who received romosozumab for 12 months followed by alendronate, there were significant reductions in non-vertebral fracture and hip fracture compared with women who took alendronate through the entire treatment interval. The adverse reactions include injection site reactions, typically mild, and possible cardiovascular risk. In studies comparing romosozumab to alendronate, there were more cardiac events in the romosozumab arm. We did not see a cardiovascular signal when romosozumab was compared to placebo. Because of that, romosozumab should not be used in patients who are at very high risk for cardiovascular events. Studies have shown that these bone-building drugs are more effective in improving bone density and in reducing fracture risk compared to bisphosphonates. Like other drugs, when these bone-building drugs are stopped, the benefit goes away quite quickly, and it's important that the patients be transitioned to either a bisphosphonate or to denosumab to maintain the skeletal benefits. When that's done, we know that both bone density and fracture protection persist for at least 2 years after transition to the anti-remodeling drug. We also know that the bone density responses to therapy are smaller in patients who are previously treated with other drugs compared to treatment-naive drugs. So in theory, these bone-building drugs would be the ideal initial therapy for all patients with osteoporosis who have experienced the architectural disruption, but they are currently recommended for use in patients at very high risk of fracture. There's some patients for whom there's special considerations. For patients with renal insufficiency, we use bisphosphonates with great caution. For the very elderly, it's important to note that no one is ever too old to treat. The fracture protection from therapy is noted within months of beginning treatment, but we often consider parenteral therapies like zoledronate or denosumab in patients who have many other drugs that they're taking for other reasons. And for patients with other confounding medical issues, as Dr. Lewicki emphasized, we need to individualize therapy. So to summarize, again, osteoporosis requires lifelong management. There is no short-term fix for osteoporosis. The choice of initial therapy should be individualized and guided by the patient's fracture risk. The optimal management will involve the sequential use of different classes of osteoporosis drugs in a whole variety of different sequences, at the end of which the final drug in almost any sequence would likely be zoledronate, where we can take advantage of its long duration of action after a single intravenous dose. We need to remember that the skeletal benefits of all drugs wane when treatment is stopped. That requires then long-term management, often with multiple drugs over a patient's lifetime. And perhaps the most important treatment that we can offer women in early menopause is hormone therapy at the time of menopause to prevent that rapid bone loss and the rapid deterioration in trabecular architecture, to minimize their risk of developing osteoporosis and fractures in the future. With that, I thank you for your attention, and again, look forward to the question and answer period.
Thank you again so much, both Professors Lewicki and McClung, for two wonderful presentations. We do have a number of questions here, so we will start out. This first one has to do with the value of repeating DEXA scan in patients who are already osteoporotic. Dr. Lewicki, do you want to tackle that one?
Well, there's different reasons for repeating a bone density test. And as with any test, it should not be done at all unless it's likely to influence your patient management decisions. The question usually comes up in a patient who's been started on treatment. And it's recommended by most guidelines that a follow-up DEXA study be done 1 to 2 years later. I like more information rather than less, so I typically will do a bone density test 1 year later, and I'd at least like to see stability, and better yet, an increase in bone density. Now, I also have a lot of patients who have osteoporosis and are at high risk for fracture, but do not want to have pharmacological therapy. And often, even though they don't want to be treated at this time, they're interested in following up to see if their non-pharmacological therapy is working or not. And again, I often have those patients come back a year later, do a repeat bone density test, and have a conversation with the patient. Is calcium, vitamin D, and exercise working, or are you losing bone density in spite of doing that? And then we'll have another conversation about pharmacological therapy. And sometimes at that point, the patient is willing to be treated and sometimes not. But that's all part of shared decision-making.
Great.
Yeah, I agree with that. And again, if we think about sequences of therapy, the reason to measure bone density in patients who with osteoporosis on treatment is to figure out what the next step in therapy is. So there's important value in monitoring response to therapy. It's important to appreciate that on treatment bone density has been shown to correlate with current fracture risk, and so is an important outcome to monitor and track while we treat patients.
I think this next one is along the treatment line. Professor McClung, there's a question here on the role of recombinant PTH post-parathyroidectomy for primary and tertiary hyperparathyroidism to prevent osteoporosis.
Yep, that's well beyond the scope of these presentations. After parathyroidectomy, then the patient is no longer at risk for the bone loss that happens because of elevated PTH. So recombinant PTH therapy after parathyroidectomy is indicated if the patient develops hypoparathyroidism as a hormone replacement therapy, essentially. So.
Let's see.
Yeah, and of course, if you've had a parathyroidectomy and a couple of years later, it's determined that you're at very high risk for fracture, certainly you could consider any of the anabolic agents at that point, including the PTH receptor agonists.
Next one has to do with the use of hormonal therapy. The question is, in the case of a woman, early menopause, 38 years old, and no hormonal therapy offered. She's now 59 and has osteoporosis. Can hormonal therapy offer protection to prevent further decline in bone density and the individual has good BMI and lifestyle? And I would, before you tackle the use of osteoporosis, just point out that from a safety standpoint, she's certainly younger than age 60 and appears to be healthy, even in patients over, if you look at the WHI in the original cohort of 50 to 80-year-old patients, the risk in estrogen only was very low. So there are ways nowadays with spacing out progestogen or using an IUD so that you don't get the systemic progestogen of minimizing the risk. So it can be used from a safety standpoint. How about from the bone protection standpoint?
Right. So estrogen given to elderly women who have already well past their phase of rapid bone loss does have skeletal benefit. Bone density increases. There are very few studies looking at the effect of estrogen therapy on fracture risk in women with osteoporosis. And that's why it doesn't have government approval as a treatment, because studies evaluating its effect on fracture risk in patients with osteoporosis have simply not been done. It's no more advantageous than bisphosphonates. So in a patient who is many years into estrogen deficiency and has osteoporosis, estrogen does not have government approval for that treatment, but would have skeletal benefit if for other reasons estrogen were decided to be used.
You know, I think there's a dose and effect relationship with estrogen as with most drugs. And oftentimes women will get started on estrogen that may be sufficient to relieve menopausal symptoms or not cause any adverse effects, and yet may not be sufficient to provide skeletal protection. This is a case where doing some tests called bone turnover markers might be helpful. They can represent the anti-resorptive effect that's being achieved with estrogen or some other drug. So the one that's most commonly used and recommended is a fasting serum CTX or C-telopeptide. If you had a baseline value and then got a follow-up test 3 to 6 months after starting estrogen, and it went down by at least 100, I think you could be happy that you're achieving an adequate anti-resorptive effect and hopefully some skeletal protection from the estrogen. And if there's less than a change of 100, then the patient may need a higher dose of estrogen or perhaps switch to a bisphosphonate at that point.
Is a FRAX score of use without DEXA scan results, and if used as a guide with assessment of other risk or lifestyle factors?
Well, yes, it can be used without femoral neck BMD. And in fact, that's one of the main reasons that FRAX was developed in the first place. There are many regions of the world where DEXA is not available or not affordable. So doing FRAX without BMD can give you an estimation of fracture risk, and in some cases is sufficient to make treatment decisions. If fracture risk is very high, that may be grounds for initiating pharmacological therapy, and if fracture risk is very low, then non-pharmacological therapy is appropriate, and if it's somewhere in the middle, then that may be an extra good reason to go ahead and do a DEXA. And in fact, that's the way the European guidelines are generally formulated, because DEXA is not as available as it is in the US. So FRAX without DEXA is often used as the initial evaluation for fracture risk.
You know, they may be getting at here in the question, I'm kind of reading between the lines, but the discussion of using it in the slightly younger patient who you use it as a risk factor marker. So no DEXA result, but using the estimation of risk that would give you the risk of a 65-year-old to suggest DEXA testing. And maybe that's part of what they're getting at.
Yeah, that it could do that, but for women, for younger postmenopausal women, particularly those in early menopause where rapid bone loss is about to be seen, FRAX will show a very low fracture risk and would dissuade consideration for therapy. But I think you have to take into account the context of rapid bone loss about to happen. And so I would not rely on FRAX to make decisions about initiating therapy for prevention.
Let's see, what is the risk of DEXA scan regarding radiation exposure?
It's nil.
Yeah, it's a trivial amount of radiation.
Right.
I live in a city that's about a mile high in altitude, and the amount of ambient radiation just from living at this altitude is about the same as the radiation from a standard DEXA study. So it's very, very tiny.
That helps to put in perspective.
When I fly to Albuquerque for the Santa Fe Bone Symposium, I'm exposed to more radiation than a DEXA test would entail.
The prevalence of severe vitamin D deficiency, or less than 20 in otherwise healthy women, is concerning. At what age do you recommend a 20-hydroxy D testing as a routine test?
I'll go ahead and take the first stab at that. I think from a public health viewpoint, it's not cost effective to ever do a serum 25 hydroxy vitamin D as a screening test. However, if there's reason to suspect somebody's vitamin D deficient, or if you're thinking of starting treatment for osteoporosis, I would like to have a vitamin D level on all of those patients.
I would agree that the severe consequences of or important consequences of vitamin D deficiency really happen when patients have very severe deficiency with values less than 10 or 12 nanograms per mil. And so I agree with Mike that it's not cost effective to do 25D level routine screening, and the U.S. Preventive Services Task Force, again, doesn't recommend that. But for patients at risk for vitamin D deficiency, that would include patients with severe renal impairment, patients with malabsorption or post-bariatric surgery, or who take drugs like Dilantin that interfere with vitamin D metabolism, then individualizing vitamin D supplements using 25D levels is important.
Next question talks about a 65-year-old age and the use of DEXA and how frequently should DEXA be used. Question doesn't talk about what the result was. I think based on the fact that you both talked how to use it in a patient that is osteoporotic or at risk in terms of prevention, let's assume that the question is saying 65-year-old normal result greater than -1. What would you do? How frequently do you repeat that? And do you use a calculator to use an age repeat time?
Yeah. If a woman is 65 and is well past the rapid interval of bone loss, then if she's otherwise healthy without important other medical problems, her rate of bone loss is very small. A 0.5% or 1% per year. So if she has a t-score of -1, it will take her a very, very long time to get to the point where bone density would be consistent with an indication for therapy. So the closer someone is to your treatment threshold, then the more frequently a follow-up would be measured. But typically, if someone does not have osteoporosis at age 65, repeating the test within the next 5 years in the absence of other important clinical features probably isn't necessary.
Yeah, well, let me just go on to mention some of those important clinical features. So if you're 65 and you have a normal T-score, but you're being started on high dose prednisone, or you're going to get an aromatase inhibitor for breast cancer adjuvant therapy, that's a whole different situation, and those patients need to be monitored much more closely.
What is the excuse me, the importance of sarcopenia and its diagnosis and treatment in managing the postmenopausal woman and the avoidance of disability and osteoporosis?
Well, certainly muscle weakness and frailty is an important component of aging, and contributes to fracture risk by increasing fall risk. So that's a very important part of the generalized aging process. If we had a treatment for sarcopenia, that would be fantastic, but we don't yet have a specific therapy. But recognizing fall risk is an important component of managing patients with osteoporosis, and employing strategies like exercise programs or programs to improve balance, to improve home safety, to improve vision, are all important components of managing elderly, frail patients with osteoporosis.
You know, that brings up the idea of fall risk assessment in the office setting. And every patient I see with osteoporosis, I evaluate their balance and muscle strength. I watch
Right.
them walk across the exam room. I see how difficult it is for them to get out of the chair and onto the examination table. I asked them to do a one-leg stand in most cases, and being able to keep your balance standing on one leg for more than 10 seconds is a good indicator that the risk of falling is not very high. If they can't hold a one-leg stand for at least 6 seconds, they're in a high risk category for falls, and often I'll send those people to a physical therapy place to work on core strength and balance.
There's a question about the difference in the quality of bone formed with the different therapeutic options. Any comment on that?
Well, there are differences between anti-remodeling drugs, which work by the increased bone density occurs because of filling in of the remodeling spaces that are open when treatment is started. That's different than the laying down of new bone in response to the bone forming agents. But none of the drugs substantially alter or impair the quality of the bone that is accrued as a consequence of therapy.
Yeah, you know, in clinical trials, transiliac bone biopsies are required exactly for that reason, to evaluate the quality of bone. And if poor quality bone were being formed by any medication, it would probably not get governmental approval.
Sure.
You have a suggestion on the use of vitamin K2 supplementation and whether to use that in the menopause transition to maintain healthy bones?
No, none of those supplements are potent enough to prevent the loss of bone due to estrogen deficiency. Estrogen is a very important and strong regulator of bone metabolism, and calcium, vitamin D, exercise, vitamin K, none of those are useful or effective in preventing the bone loss that occurs as a consequence of estrogen deficiency.
You know, I do not recommend vitamin K2 to anybody, but many patients come in and tell me they're taking it. Is that okay? And I say, if you want to take it, that's fine. It seems to be very safe, but we do not have any strong evidence that it's beneficial.
Right.
There's a question about osteoporosis bone pain and specifically about bisphosphonates, but I'd broaden that and ask, do you use any agents, calcitonin or any of the agents to help with osteoporosis pain?
The only drug that's been suggested to be beneficial is the use of calcitonin after a vertebral fracture. First of all, bone pain is rarely a component of osteoporosis. If a patient has low bone density and bone pain, then I'm thinking about osteomalacia or other problems that need to be evaluated. But there's no good evidence that any of our treatments reverses musculoskeletal pain in patients that already have osteoporosis. Teriparatide minimizes the development of pain because it, of course, prevents fractures from happening.
You know, I think the only instance where you might think of osteoporosis causing bone pain is when patients are having microfractures in the spine that haven't been recognized and yet might be enough to cause pain. And there are even situations where, and I've seen this in a few of my patients, they've had back pain, x-rays show no fracture. I've done an MRI and there is edema in vertebral bodies on the MRI. So even though there's no loss of vertebral height, there are apparently microfractures enough to show up in the MRI and cause bone pain. But these are very unusual situations.
Going to do maybe one or two more questions here. I'm going to combine a couple here. There's some questions about overlapping drugs, the use of anabolic drugs with bisphosphonates, denosumab with Romo. comments on overlapping use of medications?
Yeah, the combining therapy is not particularly beneficial. Combining bisphosphonates and teriparatide it has minimal advantage, and using them sequentially rather than in combination is better. Nobody has combined denosumab and romosozumab yet, because romosozumab has an anti-resorptive effect. Then the added benefit of more anti-resorption probably adds little to that. So again, with the data we have document the tremendous efficacy using them sequentially, and I would stick with that rather than using them together.
You know, the only potential combination that might be useful is combining teriparatide and denosumab, and in some extremely high risk patients, that's something that might be considered. For example, in a patient who's been on denosumab and continuing to have fractures and is at very high risk, rather than switching to teriparatide, there might be an advantage to adding teriparatide to denosumab.
Right.
But again, these are rare situations.
I don't know if there's any question in there either of you saw that you want to tackle as the final one. Otherwise, I'll give us one more and then we'll wrap it up. Or any just final thoughts or comments?
I'll leave it to you.
Oh, there's one here about considering in postmenopausal women with rapid decrease in BMD, and that basically by age 65 they've already gone through that. So shouldn't DEXA be performed at the time of menopause, and when they're earlier in that rapid decline phase?
Sure, and Dr. Lewicki outlined that. So the indications for DEXA are at age 65 or younger postmenopausal women with risk factors for osteoporosis, including being thin or a family history or having had a fracture. So we don't have to wait until age 65 to do bone density. If there's concern about the potential risk of osteoporosis, it ought to be done at the time of menopause so that we can take advantage of the strategies to prevent that rapid interval of bone loss.
Yeah, you know, if I were king of the world, I would do a DEXA on every postmenopausal woman, whether she has risk factors or not. Yeah, at the time of menopause.
Right.
It's not cost effective from a public health standpoint, probably, but it may be very effective for individual patients who turn out to have very low bone density.
But we would recommend that for our wives and daughters.
Right. Well, I want to thank you both. There's a ton of questions. We could probably go on all day here, and it's just a reflection of the wonderful presentations that you've both given. And I really appreciated both of you taking the time and chance to see you virtually here again. Hopefully we'll be together live soon at one of the meetings, but thank you both. There's some questions about the presentation. All of our IMS presentation, the symposiums are recorded. There'll be some information for you about that in terms of being able to watch this presentation again and look out for upcoming symposiums that we have going monthly with the IMS. So thank you very much for attending, and hope to see you all again soon.
All right. Bye-bye.
Thank you.